Welcome to ICU Primary Prepcast. Hi, my name is Swapnil, and today I'm joined by our co-host, Dr. Mike Clifford from Melbourne. Welcome, Mike.
Thanks, Swapnil. Standing in again for the currently no longer pregnant Maddie. Very happy to do so.
Thanks, Mike. Last week, we discussed about the respiratory changes during the pregnancy and at term. In this snippet, we would like to discuss about the cardiovascular changes, which are equally important. So can you please walk us through those cardiovascular changes during the pregnancy and at term?
Yeah, absolutely. So again, this is a very common question to be asked as a written, so SAQ. There's a lot of fairly predictable numbers that are used for the multi-choice. And again, in the Viva, we would expect a fairly confident description of the changes. And it almost perfectly mirrors the changes that you get in respiration. If you think about increased oxygen consumption and CO2 production, you've got to have increased minute ventilation to get rid of it. You've got to be able to match those changes with pulmonary blood flow and cardiac output to provide for the matching. So again, it's about breaking down the cardiovascular system into areas, or you can do it via trimester for pregnancy, remembering that there are changes throughout the trimesters, and essentially you get maximal change at end pregnancy or the end of the third trimester. And then there's another change when you go through labour and parturition. So focusing on the different subsections of the cardiovascular system, we'll think about blood volume, cardiac output and blood pressure, cardiac output being divided by stroke volume and heart rate. And once we've got those four flags on the page, you can write yourself a pass mark, or you can talk to the examiners in the Viva and they will hone in on one particular area and say, tell us about this. Okay, but you've already passed the Viva essentially once you've got that out. So in terms of blood volume, it's quite interesting. You get a 40 to 50% increase in blood volume. So that's about an extra 1.5 litres of blood flowing around the body, which is going to compensate for the blood loss that you'll get at delivery. There's a 30% increase in your red cell mass due to an increased production of erythropoietin. And there's a 50% increase in plasma volume, which begins in about the first trimester and has increased to about 45% due to estrogen stimulation and activation of the renin-angiotensin system. So your hematocrit slightly falls. That's the so-called anemia of pregnancy, because your increase in your water is greater than your increase in your red cell mass. You're effectively physiologically diluted. There's also a reduction in your colloidosmotic pressure, which may have predisposed to edema. In labour, you actually get an auto-transfusion by the uterine squeezing blood out of its blood vessels each time. So one contraction causes about 300 mils or a cup of blood to enter the central circulation with every squeeze. So there's fundamental changes that are even occurring all the way into labour. Now, in terms of your cardiac output, it also increases by somewhere between 30 to 50%. So that's a little bit like you can imagine someone walking continuously. So people who say that pregnant women are just sitting around resting, in fact, they're walking the entire journey. So for 40 weeks, they're not stopping, in addition to all the work they're doing just to go through life. So their cardiac output is their stroke volume multiplied by their heart rate. Their stroke volume increases by 20 to 50%. And a lot of that change is occurring in the first trimester, and your heart rate increases again by 20 to 30%. So it's about 15% in the first trimester and 25% after the middle of the third trimester. So again, there's this sort of ramping up towards the end of pregnancy. And your peak 50% increase occurs between the 32nd and the 36th week, which is about the period of viability. And that's when the baby's at their biggest, and then their growth rate is plateauing out, and your body's saying, this is as much as you have to do before you now have to go up another 50% for labour. A lot of the increase in venous return is due to venodilation and reduced vascular tone, which is a function of your estrogen level. So, and that makes sense. Whether you talk about an increase in venous return over pregnancy or an increase in cardiac output, they're mathematically matched, so it doesn't really matter. And it returns to normal at about 2 weeks postpartum. At peak, there's about 20% of blood flow to the uterus at term. So 1/5 of your cardiac output is going to the uterus, in the same way that 1/5 of your cardiac output is going to your kidneys, just as numbers to remember. Finally, your blood pressure. Your blood pressure is usually slightly decreased unless you've got some pathophysiological event going on like preeclampsia, but normally your blood pressure is slightly lowered, largely due to a reduction in your total peripheral resistance. So the hormonal effects of progesterone and estrogen on the blood system, as well as a reduction in viscosity from the anemia. And significantly, the placenta, which the uterine blood vessels act as an AV shunt. So there's no arteriolar mechanisms or capillary bed that reduce flow. You've got these enormous cotyledons where blood flows through. So it's like an AV fistula. So you've got this systolic blood pressure and then a dropping of your diastolic blood pressure, which overall lowers your mean pressure. And that decreases by about 30% at 12 weeks. So it's very hormonal. It's not because you've got this massive organ. It's a lot of it is hormonal. It goes up to 35% at about 20 weeks and then stays at about 30% or 1/3 lower than your non-pregnant values. And those progesterone-mediated changes occur through prostaglandins and some alpha receptor downregulation. The estrogen is responsible for the increase in the vascular volume and it augments the venodilation from nitric oxide production. So our systolic and diastolic pressures have decreased by about 10% from about 12 to 26 weeks, reaching a nadir at 20 weeks. They'll increase back to pre-pregnancy levels by 36 weeks, and then they'll just sort of sit there until you've delivered. Your central venous pressure and capillary wedge are essentially unchanged. Your kidney gets an 80% increase in blood flow. The gut, skin, and CVS are all pretty much the same. The other special circulations to think about in terms of cardiovascular changes, one is aortocaval compression, which is the function of the gravid uterus under gravity when a woman's lying supine, where you get compression of the IVC and the iliac veins. And that can reduce their cardiac output by 30 to 50%, which is one of the reasons that anaesthetists are trained to put women in a wedge position when they're going off to sleep to try and get that gravid uterus off the veins and increase cardiac output and increase blood flow to the uterine cavity and to therefore the undelivered baby if they're under stress. There's also changes anatomically in shape to the heart. There's biventricular hypertrophy of the ventricles, and there's a left axis deviation as the diaphragm lifts and pushes the apex of the heart up towards the left shoulder. There's also annular dilatation and an increase in your mitral regurgitation. And it's possibly partly mediated by some of the progesterone that's available to it. It makes the edges of the valves somewhat leakier and looser. And obviously at delivery is the final part where you get uterine contraction, giving you an augmentation of blood volume, but also a massive increase in cardiac output during the delivery process where they're tachycardic and hypertensive, and that the increase in cardiac output there can be up another 60 to 70% above your baseline. And obviously during labour, particularly during contractions, the blood pressure can be very high. All of those cardiovascular changes basically go back to normal over the next days to weeks after parturition, when all of that excess blood volume is no longer required. So there's a diuresis and a breakdown of those red cell products, and the maternal circulation returns pretty much to normal.
Thanks, Mike. So I was just reading some of the Vivas in the past, but I think one of the application question that has been asked in the past was about what are the kind of implications of venous changes of pregnancy. So as you rightly said, the venous return is increased by 150%, and there's a venous end of capillaries is distended, leading to reduced blood flow. And that leads to reduced subcut or IM medication absorption in pregnancy. And also in the epidural space, there are extradural veins are distended. So that's why there's increased bleeding risk during the epidurals. And the spinal canal is narrowed. So that means we need to reduce the volume of the spinal drugs. Similarly, with regards to pharmacokinetics of some of the drugs, it's quite complicated during the pregnancy. So with absorption, because of the venous dilatation and congestion, can lead to either delayed absorption of the subcut intramuscular fluid, as I mentioned. Similarly, with the engorged venous system, the stomach absorption could be increased. Distribution-wise, there's increased volume of distribution for the hydrophilic drugs. Metabolism-wise, because of the hepatic extraction ratio, the drugs with those have got a high HER will have increased metabolism. And similarly, because of the increased renal blood flow, as you mentioned, there could be again increased elimination of the hydrophilic drugs. So these are just some of the applications of these changes during the pregnancy.
Yeah, that's a good point. Sort of like in fact, we've asked a separate SAQ on the pharmacokinetic changes of pregnancy, and they are mainly a function of the cardiovascular changes. So that's a good observation.
Thanks, Mike. So that's the end of our today's snippet. We'll be back with another snippet in a week's time. Till then, goodbye and have a nice time.
See you later.